I will present a case control study, which we recently finished, and it's in the write-up. And we looked at vaccines and bullous pemphigoid. So it's just the presentation will have a basic outline. I'll present the disease and background, discuss the methods, results, and then present some discussion points and conclusions. So let's start with the disease, which we will be talking about today, bullous pemphigoid. So it's the most common autoimmune blistering skin disease. It is rare in general population, but it primarily affects people 68 at the age of 60 or over. The median age is 80. It first presents as a rash and itching, but then it develops into painful blisters and sores. The cause is unknown. Some drugs as well as vaccines were implicated in triggering bullous pemphigoid. So a bit of a background related to the COVID-19 vaccines. As we all know, there was a huge effort to develop as fast the COVID-19 vaccines as possible. And the outcome was that millions of people were saved from dying thanks to COVID vaccines. But still, due to certain reports and associations with adverse conditions or adverse events, there is a considerable percentage of people who are hesitant towards COVID-19 vaccines. And this is an ongoing concern because the vaccines were introduced as routine vaccines for certain groups. So it's important that people will understand the risks of taking those vaccines and know about the safety of them. So previously, there were case series and reports which showed bullous pemphigoid following the vaccines. But no population-based studies in the UK researched this topic. There was only one population-based study in the United States, which showed no association between COVID-19 vaccines and BP, but they looked only at the mRNA vaccines and didn't look at the dose relation. So we figured we would like to conduct a study which would be more representative of the UK population. And we wanted to provide more precise estimates of the associations between COVID-19 vaccines and BP, and perhaps inform authorities about possible risks. So what we did was we conducted a case control study design. So we looked at incident cases of bullous pemphigoid. We looked at adults, and we matched up to 4 controls to BP cases by age, sex, and GP practice. And we looked at the 3 months exposure in the main analysis for vaccination, for COVID-19 vaccinations. And we used conditional logistic regression. We looked at crude, partial, and adjusted odds ratio. And we used clinical practice research data link. 2 databases. One is GOLD, which encompasses the whole UK, and EMIS, which is for England only. So what types of exposures we looked at? We looked at the general exposure, so whether someone was vaccinated or not. We looked at the number of doses. So this was set up based on the government's Green Book on vaccinations. 3 doses were recommended. The third one was a booster dose for a healthy adult. And we looked at products which were Pfizer, Spivak, AstraZeneca, and two types of vaccine technologies. We didn't look at inactivated vaccines, and we didn't look at Sinovac vaccine because it was not available in CPRD. People in our study population were not vaccinated using those products. So in the main analysis, we looked at the crude association, but we also tested for certain confounders. But we also assumed a priori confounders. So these are conditions for which there were recommendations in the Green Book to get extra vaccinations compared to healthy adults. And also there is strong evidence that they are associated with bullous pemphigoid. So these were dementia, Parkinson's disease, and stroke. And then we tested other conditions where there was an evidence of association between them and bullous pemphigoid, perhaps not that strong, but they were also listed in the Green Book as conditions where patients were recommended to get additional doses of the vaccine. And we looked at the 10% rule. So if the odds ratio changed by 10%, we included them in the adjusted analysis. We also included in the adjusted analysis certain drugs like gliptins, antidementia, and anti-epileptic drugs, which were strongly associated with BP. And we also looked at the adjusted for anti-inflammatory drugs, which are used to treat bullous pemphigoid, but also other conditions. So they might affect the risk of BP. And we considered a strong association to be odds ratio above 2, and we did a Bonferroni correction for p-values, so to get more conservative estimates, and it's 0.005. We did two sensitivity analyses. Well, one is a subgroup analysis which looked at Charlson comorbidity index scores. There were studies which showed that this index is a good predictor for severe COVID outcomes. So we wanted to check, do a sort of risk-benefit analysis. So depending on what kind of a score you have, the risks of BP following vaccinations might be different. So we looked into that. And there was also a study on sociodemographic inequalities in COVID vaccination uptake in England. And it showed that there were inequalities in vaccination access. So we wanted to adjust that in a sensitivity analysis, which accounted for patients' ethnicity and index of multiple deprivation. So these are the results. First of all, I'll show you the study population characteristics. So the median age is in line with the literature in previous studies, which is 80 years of age. We found that there is a higher percentage of people with diabetes, stroke, and dementia in BP population compared to controls. Also to mention, there's always a slightly higher percentage of the conditions which we listed in BP patients compared to controls. This is also reflected in the second slide, which shows Charlson comorbidity index, and there's a higher percentage of people with bullous pemphigoid who had the score 3 and above. Predominantly, the patients were white. However, we also acknowledge that there's a lot of missing ethnicity data in CPRD. So this is something important which will be discussed later. Same with index of multiple deprivation. The percentages are similar in cases in controls due to matching, because we matched by practice. but we also acknowledge that there's a lot of missing data, particularly in GOLD database. So the main analysis showed that there was no association found between specific vaccine products and there was no general association between vaccines and bullous pemphigoid. However, we found an interesting association between 3 or more doses of vaccines and bullous pemphigoid, which showed a reduced risk of BP. We also would like to highlight that the analysis was additionally adjusted by multiple sclerosis and SARS-CoV-2, which will be interesting to look at when I will show the comparison with other studies. When we looked at the 2-month exposure window, we tested that to see whether there's a huge difference when we shift the exposure window, and the results were exactly similar. I think most people were vaccinated just around 2 months before getting BP. We looked at the subgroup analysis. For people with score between 0 and 2, the results were similar to the main analysis. But we couldn't find a lot of people with Charlson comorbidity index of 3 and above. And we have found no association. There were no statistically significant results. And when we adjusted for ethnicity and IMD, we had similar results to the main analysis. So discussion, I will start the discussion with comparison to one of the studies which was mentioned before, Bira Baharan et al. It's a cohort study, and it had similar results. And the good thing was that they looked at the same vaccine products when they looked at the mRNA vaccine association with BP. So we also found very similar results in our study. And we also looked at an interesting study from Hong Kong by Peng et al. And they looked at the risk of pemphigoid and other autoimmune diseases following COVID-19 disease. So they found that there is an increased risk of pemphigoid, they call it pemphigoid, following COVID-19 infection. And simultaneously, they have found out that if patients took 2 vaccines or more, the risk of pemphigoid was reduced. And we had a similar results in our study. And the authors suggested that the COVID-19 vaccination could confer protection from infection-induced autoimmunity by reducing the severity of COVID-19. So this is interesting because it's sort of in line with our results, because we also found out the SARS-CoV infection was a confounder in our analysis, and we also found out reduced risk following 3 doses of vaccine or more. So when we looked at the strength of our study, we had a relatively large study population representative of the UK, and also for a rare disease like bullous pemphigoid, we had a large study population. We selected a wide range of confounders which were associated with bullous pemphigoid, but they could also affect the exposure, and we did that based on the literature on our outcome of interest, as well as the government policy outlined in the Green Book. We did sensitivity analyses as well, which looked at specific phenomena, changes of exposure window, and ethnicity and IMD, which could imply inequalities in vaccine access. They were similar to the main analysis, and the results were also similar to studies done in other countries. but we couldn't compare the results within the Charlson Comorbidity Index analysis because we didn't have enough people with a score of 3 and above. So this is something which should be explored further. And there was also a considerable percentage of missing ethnicity in IMD data. I've tried to work on the multiple imputation, but and I use random forests approach for that, but the proportion of falsely classified index of multiple deprivation was too high to uh, include this data in the analysis. So I just put whether there was an unknown ethnicity, it had the category of unknown in our analysis. So this is a limitation. And also the limitation is that only in CPRD Aurum you can get the product and type for vaccinations. Gold doesn't have that detailed information. So to conclude, we found no association between COVID-19 and vaccines and increased BP risk. So this is reassuring, and also the fact that there is a reduced risk following 3 vaccines or more. There might be some protective effect, as suggested by one of the previous studies. But there should be some future studies which perhaps will be using new, more recent versions of CPRD or other databases to look at the differences between Charlson Comorbidity Index subgroups and sociodemographic subgroups, because based on the data we had, we couldn't estimate those. There were some limitations as mentioned. So thank you very much for listening to my talk.